2, 1.
Hello and welcome to this live webinar entitled How to Avoid Foot Complications and Stay Healthy. My name is Richard Lee. I'm consultant podiatrist at the Royal Free Hospital, and I chair the English Diabetes Footcare Network. This production this evening has been brought to you in collaboration with the networks from all 4 countries, and we have speakers from different areas who hopefully are going to provide some really useful information on avoiding foot complications. This is occurring on the eve of World Diabetes Day, and we know that there's a lot going on tomorrow, hence doing this evening. There are some housekeeping issues for this evening. I can progress that. First to say, we have, oh, I don't know why I've got a big question mark there. There we are. So the main session will run for 45 minutes, and towards the end there'll be 10 minutes for questions. You'll see that you're able to write questions in the bar at the bottom, so please do those, and we will hopefully get through as many of those as possible at the end. For any technical issues that you have, please email Emily Mayhew at the address at the bottom there. So without further ado, I shall introduce Duncan Stang, who's going to talk about the importance of foot screening and risk stratification leading to treatment and management where appropriate. Duncan spent 27 years developing and running a gold standard multidisciplinary clinic in Hare Myers Hospital in NHS Lanarkshire. In his role as coordinator for Scotland, he formed the Scottish Diabetes Foot Action Group with a remit of improving services and outcomes for people with diabetes across Scotland. His current secondment as Diabetes Foot Coordinator for Scotland is for 2 days a week since his retirement from clinical duties in 2018. In his national role, he's developed and implemented various initiatives that have transformed diabetes foot services and care delivery across NHS Scotland. And I have to say that we've also borrowed them, and the rest of the world have borrowed them. And Duncan's going to be talking about those initiatives. They include the traffic light system to define diabetes foot service delivery depending upon risk stratification, which has been adopted by Diabetes UK and NHS England and is recognised across Europe and beyond. Working alongside the Scottish Care Information, Diabetes developed and implemented a world-renowned foot screening service with the addition of an online training module supported with targeted educational leaflets and also online ulcer management systems. Duncan has also been involved in producing competency frameworks. It's now called the Capability Framework for Integrated Diabetic Care of the Lower Limb, and that's used by all different types of healthcare workers who deal with foot conditions. Duncan's developed and introduced a national campaign, CPR for Feet.
Hi, good evening. Something went wrong with the screen there, but I think I am probably speaking live now. So As Richard had said, this evening I want to talk about the importance of foot screening and risk stratification leading to a treatment and management plan where appropriate. We have to understand that we have to understand that diabetes is a lifelong condition, and consultations with doctors, podiatrists and other healthcare professionals only make up a minute percentage of the time that you live with your diabetes. And these consultations are essentially to inform you and to advise you on how best to self-manage your condition. And this is especially important when it comes to your feet. Diabetes foot screening, I generally look upon diabetes foot screening as the cornerstone of good diabetes foot care, and it should be carried out annually, and it should only really take a couple of minutes. So why should you have your annual diabetes foot screening? It should inform you of your risk of developing a diabetic foot ulcer that could lead to life-changing complications. And it informs you of who you should see and what service you should receive according to your risk and to prevent and treat problems. So, what does having a diabetic foot screening involve? The person carrying out your foot screening will visually be checking your feet for any structural abnormalities that could lead to problems. You'll see these couple of pictures here. The one on the left has an overlying second toe, and that's liable to pressure from the top of the shoe, and that could cause a rub, which could cause a break in the skin, which could then turn into an ulcer and lead problems. And the image on the right, you can see somebody has a bunion here, or what they call professionally a hallux valgus, and yet again that could lead to pressure from footwear, which could cause problems. They will also be checking during the foot screening for any areas of callus or areas of hard skin. And that is important because any areas of hard skin can cause excess pressure on the underlying tissues and the underlying skin in your feet, and that can result in the skin breaking down and possibly becoming a foot ulcer. So they will be checking for areas of hard skin. Now, I don't mean just small areas of dry skin, actual areas of hard skin and callus that could cause extra pressure. They'll also be checking for any areas of broken skin and will be assessing you to see if you can self-care, i.e. can you reach down to check your feet, or is there somebody else there, a carer or a partner who could reach your feet to check your feet for you. Your circulation will also be checked, and they will generally, when they're checking your feet and your circulation, they'll generally be checking 2 pulses in your feet. And the first pulse that they'll check, and usually using 2 fingers of the right hand, and the first pulse that they'll check is in the top of the foot. And if you see the right hand image, that is roughly where the 3 white dots are. That is roughly where the pulse is palpated in the foot. And the person will use these fingers to see if they can palpate the pulse. Some pulses are not very easily palpatable if you have a swollen foot or if the blood vessel runs slightly deep. But most people, if the circulation is adequate, then this pulse is palpable. The other pulse will be, as you'll see from the second image on the bottom on the right, is just behind the ankle bone, and this is the second pulse that they'll be checking. And if the person checking your feet can get either one of these pulses, then the circulation to your feet is perceived to be adequate. So they will also be checking, the other important check that you will have is to check if you have any lack of feeling in your feet. And this will generally be done with a 10-gram monofilament, which is a piece of nylon which will be depressed on these certain areas of your foot. And the reason that we check for this is if you have a lack of feeling in your feet, then that puts you at risk of having damage to your feet that you might not realize is there and could lead to problems. So it's very important to know if you have a lack of feeling or a lack of perception of pain in your feet, and that will raise awareness, and you can be given advice regarding that. So I want to talk to you a bit about the diabetic foot risk stratification and triage charts. And let me take you through this, and let me talk to you as a person with diabetes of what this means for you. So you'll see down the left-hand side here, this is split into low, moderate, high, in remission, and active. And these are the different levels of risk that you will be assigned when you go for a screening. And let me just spend a few minutes and talk you through what these actually mean and what they mean for you. So if you are low risk, that means you've got no risk factors, i.e. you've got, or e.g. you've got no loss of sensation, no signs of peripheral arterial disease, i.e. no poor circulation, and no other risk factors. So really what you should get in this instance is you should, sorry, I've just for some reason lost my presentation. I will take that to, that's it back. You should have an annual foot screening by a healthcare worker, agreed personal foot care and self-care management plan. And the reason it's a self-care management plan is anyone who is low risk has no greater chance of developing a foot ulcer than somebody without diabetes. So you are very capable and very able to look after your own feet because you have got no greater risk. You will have a review of footwear, and you will be provided with written and verbal education, including information on how to access podiatry, urgent or otherwise, as required. And you will hopefully be given cardiovascular risk reduction information and encouraged and signpost all people who are smokers to a smoking cessation program. If you're at moderate risk, you will have one risk factor present, for i.e. you will have maybe loss of sensation, or you'll have signs of poor circulation, or you'll be unable to or have nobody else to help you self-care. Or what is added in here is something called an eGFR of less than or equal to 15, and that means you have got real problems with your kidneys. That will not be checked during your screening process, but if you're in Scotland and they're using the Sky Diabetes system, that will automatically be collected from any previous tests that you've had in our automatic screening system. So, as you're with a patient with diabetes and of moderate risk, what should be happening for you? You should have an additional foot assessment and an agreed treatment and management plan by a podiatrist or other health care professional when required. And that is to make sure that if you require, you will receive specialist footwear and possibly insoles, and those will be fitted by a suitably trained healthcare professional or orthotist. If you are at high risk, you'll have more than one risk factor present, i.e. a combination of loss of sensation, signs of poor circulation. You may well have callus deformity, you may well be unable to self-care, or you will have this kidney disease or an eGFR of less than or equal to 15. So if you're high risk, you have got two or more of these factors. And if you're high risk, then you will have an assessment by an experienced podiatrist and referral to other relevant specialists as required. And a further review of footwear and insoles by a trained orthotist or specialist. If you're in the in remission group, you will have a previous ulcer or amputation and or a previous Charcot foot, which is in the consolidated stage. And that is the difference between high risk, that is somebody who is not ulcerated before, and somebody who's in remission is somebody who's had a previous ulcer before. If you've got active foot disease, that means you'll get presence of ulceration, infection, ischemia, or some of these other problems that I've mentioned. And what should happen for you at that stage is you should be referred to a multidisciplinary foot team or directly to vascular where appropriate. So as you'll see from the risk stratification, it starts off down at the bottom where you may well have a screening by any appropriately trained healthcare worker to right to the top of somebody who has active foot disease, and you will need specialist treatment there. And that is the complete risk stratification system as you'll have seen it. It is simple, it's visual, and it, as Richard said earlier, it is made up in the SIGN guidelines, NICE guideline, and has been adopted by many people across the UK and beyond. So what should you as a person with diabetes do? You should attend your foot screening appointment, and if you have not had a foot screening carried out in the last 12 months, inform whichever healthcare professional you're seeing that you are due your foot screening. And remember what I said earlier, diabetes is a self-managing condition. So what you can do what can you do to help prevent foot problems? The most important thing you can do is check your feet daily. And if you can't see the soles of your feet, then a mirror can be very helpful for this. I always say to my patients, when you brush your teeth, check your feet. Most people brush their teeth twice a day, in the morning and the evening, and by association I say when you brush your teeth, just have a quick check of your feet, because especially if you suffer from lack of feeling, you may have developed a problem and you might not be aware of it. So what should you be looking out for? Any breaks in skin, any areas of heat, any areas of redness, inflammation or blisters? You should check between your toes and the soles of your feet, and as I said, use a mirror if you need to. I would also say you should be applying moisturising cream. I would apply it daily, but don't put it between your toes. That can cause the area to go a bit mushy, so we don't want it between the toes. And it can just be simply applied while you're doing that quick check of your feet. And if your skin is very dry, I would use a urea-based cream, as this is very helpful, especially for people with diabetes. And this can become a prescription item for you. Most people with diabetes can deal with their own toenails, or your partner or carer can, but I would advise don't cut your nails too short and don't cut them down the side. But I would say follow the curvature of the end of your toe. Don't leave a sharp corner on either edge, and use a nail file to ensure that there are no rough edges. Use a nail file on a regular basis if you are unsure about cutting your own toenails, and if you have been advised by your podiatrist not to cut your own toenails because they perceive that you are at a high risk of causing a problem, then follow that advice. So footwear, I want to quickly talk to you about footwear. I would say definitely get your feet measured and don't fall into the trap of buying a bigger size, because that will just, if you buy a bigger size, that will mean that your foot won't be held snugly in the shoe, and it could mean that your foot moves back and forward, which could cause problems. I would also say that lacing shoes are the best option, as they do hold your foot in a much better position. And when buying new shoes, I would break them in by wearing them around the house. First of all, the reason for this is if once you've worn them for a short period, if you see that they are rubbing in certain areas, you should be able to take them back to the shop if you've not worn them outside. And when you do wear them just outside, just wear them for short distances to begin with. And if you require prescription footwear or insoles, you will be advised by your podiatrist on this. I would also say check your footwear every time before putting them on, because you never know, something might have dropped into your shoe, and especially if you've got lack of feeling, you might not feel that, and it could cause a break in the skin. Or run your hand inside the shoe and see, make sure that there are no rough or worn areas that could cause a problem. I would also say never walk barefoot. This can put you at further risk of walking barefoot, especially maybe even getting up in the evening without a light on. Quite often, a lot of my patients maybe kicked a bedside cabinet or the foot of the bed, and that can be a problem. So I would say try to avoid walking barefoot, because you may well stand on sharp objects, and as they say, stub a toe. And when you are on holiday, this can also be a challenging time. So be aware, especially when you're on holiday, that your activity can change, and especially if you're on a beach holiday in a hot country, areas of hot sand and round swimming pools can get warm. So I would be very careful of those times. There are risk-targeted leaflets, which you will see from this slide. There is a web link there. I'm pretty sure this is going to be made available to you after this talk, so there's no need to write it down. But they are available via the College of Podiatry, and as I say, they are targeted to your risk, which is specially tailored advice for you for your risk. So what should you do if you do notice a problem? The first thing is, do not delay. Contact your podiatrist, practice nurse or doctor. Most diabetic foot problems are treatable, but receiving the most appropriate treatment quickly is absolutely paramount. Don't just think, oh, it will be fine and this, that and the other. No podiatrist, practice nurse or doctor will give you a hard time for contacting them, because it is something that you have to get dealt with very quickly, because any diabetic foot problem, especially an infection, can travel very, very quickly. So, in summary, make sure you have your annual foot screening. Know your own risk and know what that risk means for you. And know who to contact if you have a problem. And if you are not sure at the moment who that is, make it a mission to find out who is the best person for you to contact, so that you have that number or the location of that person available to you. And most importantly, probably the most important thing that you can do is check your feet daily. So remember, my strap line for when I'm talking about checking your feet is, remember, when you brush your teeth, check your feet. And if you do that, and do that on a regular basis, that will stand you in very good stead. Thank you very much for listening, and I think any questions that are going to be fielded on the chat bar will be taken at the end of this session. Thank you for listening.
That was great. Thank you very much, Duncan. Some really helpful advice. And yeah, the foot checks are definitely really extremely important. Our next speaker is going to talk from the patient perspective. Our speaker is Richard Lane, OBE. Richard is 77 years old. He's married with 2 children and lives in Beckenham in Kent. Richard retired as a partner in a chartered accountants in 2003 through ill health caused by type 1 diabetes. He has always been very heavily involved in a range of business, charitable and other community activities, and is now, amongst several other voluntary responsibilities, heavily committed to supporting Diabetes UK. He is president of Bromley Cricket Club. Richard has been as he describes, serious and brittle type 1 diabetic since 1976. Treated with insulin injections and then with an insulin pump. He ultimately suffered from a substantial number of hypoglycemic reactions, most of which increasingly had little or no warning, and many developed into frightening comas, and from a range of awful complications associated with type 1 diabetes. Between 2004 and 5, he received 3 islet cell transplants at King's College Hospital, London, in the care of a team led by Professor Stephanie Amiel. From this amazing research project, he became the first type 1 diabetic in the UK to be able to stop taking insulin. He is currently back on insulin, dispensed through an insulin pump, but the treatment continues to provide him with an astonishing improvement in the quality of his life and in the lives of his family. In accordance with the primary purpose of this treatment, major hypos have been largely eliminated and warnings of all hypos restored, and the complications he was suffering from have been stabilised. He is proud and privileged to have been appointed President of Diabetes UK in November 2008. He retired from this role in November 2015, at which point he was appointed as their inaugural ambassador and continues to actively support the charity. He's spoken on a substantial number of occasions all over the UK and in Europe, principally on behalf of Diabetes UK and King's College Hospital, about his remarkable treatment and the extraordinary transformation this has made to his and his family's lives, about his meteoric rise to become president of this wonderful charity, and of course about the charity itself and its current achievements and objectives. He will never be able to thank Diabetes UK enough for funding this research and treatment, Professor James Shapiro for developing it, Professor Amiel and all the King's College Hospital for providing it, and subsequently caring for him so superbly. Over to you, Richard.
Thank you. Thank you very much indeed. I'm sorry that was such a long introduction. It's my fault because I wrote it. But anyway, it is a privilege to be here, and I'm absolutely delighted that the diabetes foot, which is probably one of the greatest concerns and passions that I've had since I was first diagnosed, is the subject of this webinar tonight. Probably in just about every one of the, I believe, 800 speeches I made around the UK and in Europe while I was president and just before, in those speeches I referred to diabetic foot problems because it is my passion. I've seen so many terrible situations arising from poor care, or should I say from no care, and I'm absolutely determined that I will do the limited amount I'm able to do to try to put that right. I have to say that since I started, the quality of foot care around the country, which I used to refer to as being on a postcode lottery basis, has very much improved, but not everywhere. And I'm again determined to try and help make sure that that does happen as soon as it possibly can. Complications arising from diabetes foot problems are devastating, or can be, especially if they're not quickly discovered and treated at a very early date. And therefore, as a summary to this opening bit, I just want to thank the organisers for putting on this incredibly important webinar. It really is of great importance. Proper foot care, and I'll talk about that in a moment, although Duncan has already dealt with it far better than I can. But proper foot care is an absolute entitlement of every person who has diabetes. Although the situation is definitely improving, the importance attached to providing such care is still disappointingly varied around the country, and attention needs to be given to raising standards to a higher minimum level without delay. So what do I mean by proper foot care? And I'm just a mere amateur, just a patient. Every person with diabetes, as Duncan has explained, should be given a foot check every year, whether at the GP practice, the health centre, or in the hospital diabetes clinic. And then, if required or requested by the patient, a full and specialist examination of their feet by a properly qualified podiatrist. It is simply no good the healthcare professional relying on an answer to the question to the patient, how are your feet? Now, believe it or not, that used to be a very common way of people answering my questions when I used to say to them, have you had a foot check this year? And they say, oh yes, definitely. And what did it constitute? What happened at your foot check? Oh, that people used to say, the nurse would say, how are your feet? And I just looked at them in amazement, realizing that they had not been asked to take their socks and shoes and stockings off and have their feet examined. That is just unacceptable. Excuse me. When I was first diagnosed and referred to King's College Hospital, where I've been lucky enough to be brilliantly treated ever since, foot care did not attract the same level of importance as it does now. But once I've been referred to Professor Michael Edmonds' diabetic foot clinic at King's by my then diabetes consultant there, Dr. Peter Watkins, I quickly learned how vitally important foot care is and how potentially disastrous problems can be spotted right from the outset and treated accordingly. That includes, for instance, a condition that I suffer quite badly from, neuropathy, which is a hidden complication and is very unpleasant for those who have it and those who understand what I'm talking about. I still get shooting pains through my feet at night especially, but the treatment, funny enough, that I probably shouldn't tell you this, but the treatment that I'm being given at the moment by Professor Edmonds is to squirt Opsite onto my feet morning and night. And would you believe that actually works and stops much of the pain? But nevertheless, Opsite can be treated with a series of drugs and other treatments, but it is a condition of complication of diabetes which is most unpleasant and does need to be attended to. I'm also under the care at King's of the orthotics team, who again are marvellous, and they present a priceless service to help ensure that my life as a diabetic is as trouble-free as possible. The specialists in the orthotics department provide me with specially designed and manufactured shoes, which ensure that my feet are as comfortable and trouble-free as they could possibly be. I know I'm lucky with all of this, but every person with diabetes must be granted access to this level of expertise when necessary and in due course. As Duncan's explained, patients need to be educated and helped into showing how they can carry out basic and regular checks themselves, preferably on a daily basis. There are many leaflets from the College of Podiatry and from Diabetes UK, and indeed the NHS, and online information to back this up. Campaigns such as Diabetes UK's Putting Feet First are brilliant, but it is probably irresponsible to expect elderly and non-IT literate people to rely on information technology for this purpose. Diabetes clinics, GPs and health centres have a major role to play in all of this. Patients of all backgrounds need to understand in simple language how they can avoid foot problems for the future, but also what to do if they suspect that all is not well and that expert attention and advice is urgently required. And Duncan, of course, has dealt with that, so I won't go into that anymore. Diabetes foot care must be an essential element of a fully integrated diabetes service offered seamlessly to all people with diabetes of whatever type. Simply asking patients, as I've said, at their annual or 6 monthly checks, how are your feet, must be something of the past, and that is irresponsible and ineffective to rely on that. The complications that can easily develop, often silently and without prior warning, can be devastating, leading to ulcers and even amputations. Apart from the high cost of caring for people who've had to suffer amputation, the effect on the patients can be catastrophic. It could be loss of jobs, vastly reduced quality of health, personal relationship problems, and financial problems. And of course, sadly, I have to say this, even death. I have talked to so many people who have suffered in this way, and they have generally left a profound effect on me, which has dictated my determination to help ward off this totally avoidable problem in the future. So to conclude, In my opinion, it's beholden on the NHS to ensure that every person with diabetes of whatever type, wherever they live, receives a full and proper foot examination by a qualified podiatrist every year, and has the results clearly and fully explained to them, with issues identified properly and a treatment program established. No longer must the Diabetes Foot Service be considered as the Cinderella service of the NHS. Diabetes Foot Service staff that I have met want and are determined to deliver this. Thank you very much.
Sorry, I was muted. Thank you very much, Richard. I was just saying, I think it's very good that we have a patient voice and that we listen to what our patients are saying to us as clinicians, because we're quite good at giving out advice and so on and so forth. But actually to get that sort of background from people like yourselves is so important, because it shows that foot checks and prevention of foot problems is really important. And something I've always said to people having their annual diabetes review is when you get into the clinic, take your shoes and socks off. And hopefully that gets away from those questions of how are your feet, which is so important. So moving on, we're now going to have a talk about foot care during COVID-19. This is going to be given by Brona Monahan, who is consultant podiatrist in diabetes in the Belfast Health and Social Care Trust. She qualified as a podiatrist in 1985, subsequently completing a research master's at Queen's University Belfast. Brona has over 30 years clinical experience working in diabetic foot management and is a member of the Northern Irish Diabetes Network. As chair of the Diabetes Foot Group, she's been involved in setting the strategic direction of the diabetes foot services across the region in Northern Ireland. Over to you, Brona.
Thank you, Richard. Can I just check if I'm live? I'm hoping, yes, I am. Thank you, Richard. That's great. Okay, we're living through extraordinary times at the moment with the COVID pandemic, and it really does challenge our healthcare services. And I'd like to talk just for a very few minutes about how we maintain good foot health during this time. The governments across the UK have consistently advised that we stay at home to help reduce the spread of the virus. But they have also been consistent in sending the message out that if you have a medical appointment, if you need medical advice or help, then it is appropriate for you to go out and receive that care. I think it's fair to say that as podiatrists, we have been worried that perhaps people have delayed coming forward looking for help because of their concerns of coming out and coming into a hospital or coming into a community clinic. And the first thing I would really like to say loud and clear is that diabetic foot clinics, diabetic community clinics, foot community clinics are open for business and do want to see you. Our priority, and I think I speak for diabetic foot clinics across the land, is to keep you safe. All clinics have very, very high standards of hygiene, but there is no doubt that with the virus, we have had to review how we do things, and we've had to take some enhanced measures. Deep cleaning, more frequently than would have been done in the past, ensuring we're using the right products that target the COVID virus. Obviously using personal protective equipment. You will have seen your podiatrist wearing gloves and aprons as a standard, but we're now wearing masks and when required visors also. And we want to maintain social distancing. And we have been taken on a number of measures to try and ensure we can do that. So you may find now when you go to the clinic that perhaps somebody meets you before you come in, escorts you to the clinic itself, and when your treatment's finished, they take you out. And that helps reduce your contact with other people in the waiting area. We're reducing our clinic numbers, which again means there's fewer people actually travelling through the clinical area. And we're taking longer breaks between the appointments to ensure that we can carry out that deep clean. And all of these things together help keep you safe while you're at clinic. Now, Duncan has spoken very clearly in terms of what you can do to take care of your foot health. And there is no doubt one of the most important things is actually knowing who to contact and where your local team is if you have a problem. Duncan has gone through what you need to do if you have low risk or you're moderate risk or you're high risk. But the thing that I would just like to talk very briefly about is foot emergencies, because irrespective of what your risk is, sometimes you might get into a bit of bother and you might develop a problem. And if it's one of these, I would like you to consider it as a foot emergency, and I would like you to get in touch with your clinic as soon as possible. Simple things, bit of redness at the side of a toenail might suggest an ingrowing toenail, might suggest infection. Perhaps a sore appears on the sole of the foot, and that's where Duncan's message of check your feet when you brush your teeth is really key. If you're looking at your feet regularly, then you'll pick up on these things. If you have a blister and it bursts and you can see that you have spreading redness around that area, then you need to have someone check that out for you. If you have spreading redness up the foot for no apparent reason, or perhaps spreading from a cut on your foot, again, that's a foot emergency. And likewise, if you develop a hot, red, swollen foot, particularly if you can't work out why this may have happened, please contact us and let us have a look at it so that we can draw up a plan to manage this problem. So remember, if you have a problem, contact your local clinic directly. Make sure that whoever you speak to, because you'll be phoning initially, understands that you have diabetes and describe your problem to them. The important thing is that you do not need a referral from your GP if you have a diabetic foot emergency. Either your local clinic, if you normally have one that you go to, or if you need to, the diabetic foot clinic at your local hospital will want to hear from you and will want to see you. If you have active disease, so you already do have an infection or an ulceration, then there are things that are really important through these difficult times. Keep attending your appointments if at all possible. Contact your clinic if you're not able to do so, and we can talk about alternatives to ensure that you still have some care. But if you have concerns or you're worried about how you get into the clinic, or you're worried about how you protect yourself when you're in the clinic, share your concerns with your local podiatry team and discuss them and talk them through and let them reassure you that it is safe to come to clinic. Some people may be self-isolating, and there are different ways we can continue to help you manage your active foot condition. So it may be possible to have home visits, and that can be discussed with your team. Dressings can be provided for you or a family member, and you can actually carry out the regular dressings yourself. Lots of teams have been using virtual consultations, whether that's by telephone or actually using the likes of platforms like Zoom, and both having visual of your foot and discussing how it is doing. Other teams are having you send photographs in of your foot so that they can look at them, give you a call, talk through if things are improving or if there's other steps that need to be taken. The most important thing is to keep in touch. Do not, when you're perhaps self-isolating, think that the foot no longer matters. It matters even more. So keep in touch, talk to your team. We're all in this together, and I think by working together we can help avoid serious foot problems during these very difficult times. Thank you.
I've done it again. There we are. Thank you, Brona. A very useful insight into where we are in these difficult times, and certainly a few questions have come up relating to that. And so, if I can maybe start with Ian has sent a question saying he had an annual check this week, but would not check feet due to COVID. Do I self-refer to hospital podiatry or wait another year? I think, what do you think of that, Brona?
So I think that we are in difficult times, and although we're all open for business, I guess business isn't as usual. So we are doing things differently, and that might mean that if you are unable to go for your annual screening appointment, you may have to delay it. But what's most important, if you're not able to go for your annual screening appointment, is that you continue to check your feet daily and that you keep in touch with us if there is a problem. That's the most important thing. But I do think during this difficult time, some aspects of the foot services may be affected and may not be just as responsive as they normally would be, such as the screening programme. But we can still check our own feet. We can still keep on top of it that way.
Great. I think that's very good advice. So yes, make sure when you're brushing your teeth that you're checking your feet, and hopefully you can have a risk assessment before too long. I've got a question here, I think probably for Duncan, from it's anonymous one, but it says, would a deep ulcer on the ankle that took 3 months to heal after surgery for a broken ankle count towards the risk score?
That is quite a difficult one, actually, because it may well not have been due to the diabetes. If you'd had surgery on your ankle and the surgical wound had become infected and maybe ulcerated, I would say that it showed that you were more liable to infection, you were more at risk, but it might not have been completely due to your diabetes. But certainly, if your tissue has broken down post-surgery, it is probably because your circulation is not as good as it could be. And I would be actually interested to see what risk you were at your last screening, and to see if you did suffer from things like neuropathy and poor circulation. But anything on it's usually anything below the ankle, which is considered a diabetic foot ulcer, not maybe on the malleoli or the ankle bone or above the ankle. Most diabetic foot ulcers are on the periphery of the feet and the soles of the feet and the toes. So I would say that if you've had an infection, your ability to fight infection and to heal if it's taken that long to heal, is compromised and you are further at risk. It may well be to do with your diabetes, so I would be taking extra care.
Great, thank you, Duncan. I have a question here for Richard. Somebody is asking, what opsite spray are you using?
Do you want an honest answer? I didn't know there was more than one. Anyway, it's the normal canister of opsite that's used for spraying on open wounds. And I can tell you, because of the pandemic, I normally go to King's every 3 weeks for treatment on my feet. I haven't been able to do that because of the pandemic. I've been going to an off-site clinic that they've set up at the Princess Royal University Hospital in Bromley, and they didn't seem to have a stock of opsite, which was most inconvenient. But anyway, so I had to buy some, and I couldn't believe how expensive it is. So I was rather pleased when I was called to go into King's this week on Tuesday and again yesterday for a particular problem I have got on my feet, and they very kindly volunteered to stock me up with opsite. But I'm sorry, I don't know the different types of opsite, but it is quite extraordinary the effect it has. It's not very pretty on the feet. It makes a horrible mess of the feet, but my word, does it work. Brona, do you know what type of opsite it might be?
Well, I think opsite is the probably generic term.
Yeah.
And I suspect it doesn't actually matter which one you use.
Okay. But it certainly works.
Yes, and along the same lines, I've had a question about what is the thinking behind using opsite spray, and I think there is evidence out there that occlusion actually works. So there are two effects with the spray. One is that it forms a film over the skin, which is occlusive, and the other is it's really quite cold when it goes on. So there may be an effect from that as well. So I think that's the background to it.
I got told off. Can I just say, I got told off by telling people about this at one rather large gathering I was speaking to at a Diabetes UK conference, because the local National Health Service people suddenly had a fit about the cost that was going to accrue for people suddenly demanding opsite for their neuropathy. But if it works, then we somehow got to find and making it available.
Absolutely. I've had a question here from Pip, and who's saying, I have real problems getting shoe slippers to fit me as I have a lot of swelling in my feet and ankles. One foot is worse than the other. So I'm finding that I have to get men's shoes sometimes. What I want to know is, where is the best place for me to get footwear that fits? Should I be looking at getting a pair especially made for me? Thank you. Possibly that question to Duncan.
Well, yet again, that's a difficult one. Where is the best place to buy slippers? I couldn't tell you. I don't know where the person stays. I stay in Glasgow in Scotland. I could direct them towards shoe shops here, but basically I would say don't wear slippers that are ones that you would just push your foot into and the back is open. I would make sure it's an enclosed one. I would go for one that was adjustable, which maybe had Velcro straps, so that you could have one tighter on one foot than the other if you've got one foot more swollen than the other. And I do, as you have said, I do recommend that, although they are not the prettiest things, for a female patient to maybe access male slippers just because of the extra room they have in them, but try and find one with Velcro. Maybe Brona, you might know of local advice that you give your patients, and you might be able to put a different slant on that?
Yeah, I think it's a really complicated issue, and particularly if you do have a variation in foot size, it is not easy and it's not straightforward. And like you, I would be aware of local places in Belfast that I might advise. As we know, there are a number of catalogue companies who sell footwear. One of the benefits of them are, by design, they're almost just what you've described, Duncan. They're often extra wide, extra deep. They have Velcro straps which make them easy to adjust. One of the bonuses of buying from these companies online is you can try them on in your own home, and if you do not like them, you can parcel them up again and send them back. And that's often one of the avenues I suggest to people, is to try buying things online, test them at home. And the other thing I often say is, if you have bought something and you are due to come to your podiatrist, bring them with you. Don't wear them, but bring them with you, and then they can check them over with you to see how well they fit.
Hi, sorry, Brona, I was just wanting to put in that I think that is excellent advice to get this slipper sort of style footwear from these catalogues. I think the one that comes to mind to me is something like Cozy Feet or something like that. Not that we want to talk about certain brands, but that's just one that comes to mind. But we have to say that I think in the case of slippers and things like that, it is appropriate to be buying these online, but from these catalogue sort of companies. But for normal footwear, we would generally not be advising our patients to be buying these online. In some cases that might have to be the case if they can't access anything, but we would hope people would maybe go and get their feet measured for normal footwear as a last resort. But I certainly totally and utterly agree with you that for this slipper situation, that is probably the best way if somebody is struggling.
Can I just add something? And I may not be very popular for saying this, but presumably in extreme circumstances, especially where the 2 feet are different, one from the other, the hospital might consider asking orthotics department to make shoes for that person. I've certainly had, I don't want to go and cause a massive run on the NHS's limited resources, but I certainly have had huge benefit from having shoes made for me through the orthotics department at King's. It made a colossal difference.
Richard, I would just like to agree with you totally, and I think that if you have 2 very different sized feet for the proper footwear, everyday footwear, then it needs to be a professional orthotist who is assessing you and measuring and prescribing. And I think that's the only, probably one of the only routes open if you have feet that are different size and shapes. Yeah.
Agreed. Yeah. Which is what I had. I had terrible swelling on one foot, and it just required that, and I can't thank the NHS enough. Mm.
Okay, have we got time for one final question? Somebody's asked, it's Dave, has asked, I use foot cream containing 10% urea. When would I request cream with, say, 25% urea? Yeah, Duncan, if you want to.
Normally, you would use the 25% urea cream to begin with when your skin was very dry. I think this is the advice from certain companies that provide this. When you first require it, to get your skin into better condition, you would probably use the 25%, and then you step down to the 10% as a maintenance dose for the cream. And quite often, maybe if you think that you're maybe needing to step up to the 25% again, it could be that you're not applying the 10% often enough. From my experience, that is the case. So sometimes they will try you on the 25% to get your skin in better condition, then they'll step you back down. But if you're thinking on using the 10% that you might well need the 25% again, I would first look at how often you're applying it. And if you do apply it daily or as directed, and you still feel, they may well put you on the 25% for a short period again, and then step you back down to the 10%. In my experience, that's what is the best route for that.
I think that's a very comprehensive answer. Thank you, Duncan, very much. As it is, there are loads of questions here, but we've run out of time, unfortunately. So I'd like to say a huge thank you to our speakers this evening, and to all of those of you who've joined us online. I'm sure this has been really helpful for a lot of people, and I'd like to thank not only the speakers but also the College of Podiatry who've helped to put this together, and Orange Juice Communications who have managed to get us round all our IT issues. On top of that, they will be putting this onto YouTube, so this will be available, and a link will be sent out to everybody, so you'll be able to watch this again just in case you missed some of those important slides earlier on in the evening. And so it remains for me to say, have a very good evening, everybody.